Welcome, everybody. We'll give it a few more seconds before we get started. Thank you so much for joining us today. Lovely. I think we have critical mass. So let's get started so that we can keep everybody on time. Good morning, good afternoon, and good evening to anyone joining us today. My name is Alan Dominguez, and on behalf of IDDSI, I'd like to welcome you all to today's webinar titled IDDSI, the nitty-gritty, the nuts and bolts of implementation, plus some information on the 2025 IDDSI Symposium. Thank you for joining us this afternoon. I'll just go through some quick housekeeping. First of all, this webinar is being recorded and will be available on the IDDSI YouTube channel in a few days. And we invite you to share that link with anyone who might benefit from listening and watching this content. Second, your microphone and your video will be off for the session. So the panelists will not be able to hear or see you. So you don't have to worry about that. However, we invite you and encourage you to submit your questions throughout the session using the Q&A button in your Zoom webinar menu, and the panelists will have about 15 minutes at the end of the session to address relevant questions. So please do be engaged with us throughout the session. And lastly, there is no need to send us an email for a certificate of attendance. We do not currently offer CEUs, but you will be getting an automated certificate of attendance for the session, and you can expect that in your inbox at the email address that you used to register for the session by tomorrow, and that'll be coming again automatically to you, so no need to follow up with us. We trust the technology. That is it for me. So I will now introduce Dr. Luis Evercalme, who is the co-chair of the IDDSI Global Board, to lead us and get us started. Welcome, Dr. Evercalme.
Thanks so much, Alan. And thank you all for being here this morning, afternoon, or evening. I am thrilled to welcome our speakers today and really appreciate that they are here and willing to share with all of us the nitty-gritty of implementation. Just as a reminder, you do know that we have an upcoming symposium on July 25th in Newport Beach, California. So certainly go to the IDDSI website, and at the end we'll have a QR code for you to also see more information on this great one-day event, also focused on implementation. So to get this going, let's introduce you to the speakers of our nitty-gritty implementation session today. Renee Canadet is an advanced practice speech-language pathologist at Hines VA Hospital near Chicago, where she's a primary member of the facility's IDDSI Implementation and Training Group. She specializes in dysphagia with a passion for exercise-based treatment and patient caregiver education. Renee also works with children with dysphagia in an outpatient clinic setting. She's co-chair of the US IDDSI Reference Group Education and Training Committee. Caroline Carey Wade is a clinical assistant professor and medical externship coordinator and speech language clinic director at Indiana University Bloomington. She specializes in adult dysphagia management with a focus on neurodegenerative populations. Prior to joining academia, Carey worked clinically as a medical speech language pathologist across the continuum of care. She has experience with IDDSI implementation and training within a large healthcare system. Carey is also co-chair of the United States IDDSI Reference Group Education and Training Committee. And I'm also happy to introduce to you Michael P. Salvatore III. He's a chef and founder of Bacchus Hospitality Group, a multifaceted food solutions consultancy formed in 1999. Mike has over 35 years of culinary management and ownership experience. He has owned 2 fine dining restaurants. Additionally, he possesses an extensive product knowledge, procurement, and sourcing expertise after 15 years as Director of Culinary Resources for Cisco. Chef Mike specializes in food service solutions that deliver profitable sales, a positive team atmosphere, and guest delight. He has led total project management. He's an active member of the US IDDSI reference group. Welcome to you all. I know this will be a great session, so I leave it to you, dear presenters.
Okay, we're ready for the next slide. Here are the learning objectives for today's session. Next slide. And here you'll find the disclosures for the three of us. Next slide.
Hello. So starting a facility-wide transition of any kind can feel very overwhelming, and the IDDSI implementation process is certainly no different. If you are here today, we know that you are considering this undertaking. We've identified 3 of the most likely pre-implementation starting points to guide our discussion today. First, I want to learn about IDDSI. Where do I begin? Next, I'm ready for IDDSI, but I need to get my facility on board. And lastly, my facility wants us to adopt IDDSI, but how do I start? Next slide, please. So let's start with I want to learn about IDDSI. Next slide. So what is IDDSI? IDDSI stands for the International Dysphagia Diet Standardization Initiative. The IDDSI framework is a global texture-modified diet standardized for all languages, all people, and in all settings. The framework consists of a continuum of 8 levels, 0 to 7, where levels 0 through 4 are liquids and 3 to 7 are foods. You can see here that each level is represented by a written label, a number, and a color. It's very specific, descriptive, and extremely user-friendly. Next slide, please. So diving in a little more to the definition, IDDSI is international because it's used globally. It has been so far adopted in 30 countries and has been translated into 13 languages with more to come. It's dysphagia because it's intended for people who have trouble chewing and swallowing. It's a diet guideline for describing texture-modified foods and drinks appropriate for people with dysphagia. It's the standardization of diet orders to simple words that translate well. Each diet has a standard terminology, numbers, colors, and symbols. It's an initiative that started in 2013 to reach a consensus around the world on how to identify, describe, prepare, and serve safer food and liquid textures for people with dysphagia. Next slide. The very best starting point and truly a point of reference for you during the implementation process and beyond is the IDDSI website, www.iddsi.org. I cannot stress enough how much valuable information is available on this website. We will highlight a few key pages and documents to support your journey, but I really encourage everyone to go to the website and just take some time exploring. Next slide. So one great place to start is the framework documents. They provide detailed information on each level through definitions, images, and easy to follow testing instructions. And you can see here from this screenshot that it is available in several languages. Next slide. The US IDDSI reference group is another great place to explore. The main page includes links to training videos and PowerPoints, frequently asked questions, research, and a variety of resources to help you advocate, implement, and prepare for regulatory surveys. Here we're highlighting the training video and competencies page, including a PowerPoint entitled Why IDDSI that can serve as a nice starting point for those of you just getting your feet wet. Next slide. This brings us to our next starting point. I'm ready for IDDSI. How do I get my facility on board? We know from our own experiences, surveys we've conducted, and speaking with others that lack of administrative support can be a barrier to starting this implementation process. Next slide. Without going into too much detail, we've identified the following 5 talking points to support your gaining facility buy-in. First, define IDDSI and why it was established. Provide information on the IDDSI framework and discuss why food texture and drink thickness matters to your patients. Next, describe how IDDSI promotes safety by improving communication of diet orders both within and between facilities, reducing errors when describing diets, transcribing diets for new admissions, and reducing the risk of choking, aspiration, and/or other negative health outcomes through providing patients with a more consistent and accurate diet. Highlight how IDDSI aligns with regulations. Regulatory compliance guidelines require facilities to align with accepted standards. As of October 2021, IDDSI is now the only professionally recognized standard of care for textured modified diets in the Nutrition Care Manual of the Academy of Nutrition Dietetics for the US. It is full support of the AND, as well as the American Speech and Language Hearing Association, ASHA, and the Association of Nutrition and Food Service Professionals, ANFP. Identify financial considerations. For good or bad, cost impacts every decision made by an institution. Lay out those potential costs, such as for food, possible equipment upgrades, and time for planning and implementing your on-site team. Discuss the timeline and process for implementation. We found that this time frame tends to vary from 6 to 18 months. Next slide. So the great news is that the US IRG has developed a PowerPoint already that dives into each of those points that I just sort of breezed over for you. So it's a nice PowerPoint that you can share with your administration and maybe supplement a little bit with some statistics or some information on your particular population and facility. Next slide. So our third starting point is the facility wants us to adopt IDDSI. Where do I go now? Now, whether the institution has passed down a directive from above to implement IDDSI or you've laid the groundwork with your administration, it really brings us all to the same place. Next slide. So here we are. It's time to implement. And with that, I will pass the baton to Carrie. Next slide.
Now let's talk about the actual implementation of the IDDSI framework. All 4 of these components listed here are very crucial to consider: building your team, setting a timeline, food mapping and building a menu, and staff training. We will take some time to discuss each of these in more detail. Next slide. When you think about team building, you'll need to consider who should be a part of your team. The most successful implementation team will include members from a variety of disciplines, and that is really specific to whatever type of facility you might be in. You'll also need to carefully consider the best and most effective team structure for you and your facility. This could include something like a committee-based team in which different disciplines have representatives, like speech pathology, registered dietitians, chefs, food service workers. Or your facility might benefit more from a team-based approach in which each discipline executes specific tasks that pertain to their scope of practice. For example, speech-language pathology pertaining to education and training, and registered dietitians pertaining to menu building and food mapping. Next slide, please. We've listed some potential interdisciplinary team members with specific roles. For example, a dietitian or a speech-language pathologist might serve well as a possible team lead for a committee-based approach, or as a committee chair. Your registered dietitian would most likely be involved in testing, food mapping, menu creation, and staff training and education. It's important to consider including team members for all healthcare staff that have daily workflow that is affected by IDDSI implementation. And this chart that you see here is by no means an exhaustive list. Next slide, please. After you've determined your team, how it should be composed, and the members that should be included, the next consideration should be your timeline. Some of your facilities will already have a predetermined go-live date for you, while others will collaborate with you to determine the most appropriate date. Prior to completing all of the tasks involved with implementation, which is no easy undertaking, you should set specific guidelines for tasks, such as completing testing and mapping of your current menu items, creating and testing new recipes as needed, training staff throughout the facility, and ensuring that you're changing signage on the floor and components of diet orders in the electronic medical record system. Next slide, please. Here you will find an example timeline. This one might be well suited for a long-term healthcare facility. As you can see here, it's only 6 months. A larger hospital or a large healthcare network or system that's composed of numerous hospitals or outpatient clinics that are within a system might take 18 or 24 months for the full implementation timeline. And I'd like to share a little bit in terms of my experience with IDDSI transitioning and timelines. I was within a large healthcare facility in which the transition, our go live date was approximately 18 months from start to finish. I was also a part of IDDSI transition for a smaller hospital that was within the same healthcare network, and that go live timeline was only 6 months. So again, it's really facility dependent and can not only depend on the continuum of care that you're in, but also the size of your facility. And now I'm going to turn it over to Mike to talk more about food mapping.
Thanks very much, Carrie. So starting with your menu, the most important thing is to establish the why that you are going through this transition and upgrading to IDDSI. The stronger the why, the better the buy-in. When mapping your foods, realize what your population needs are. Depending on your type of facility, will dictate how far across your menu you'll need to spread texture modification. Take a look at what you're currently modifying now. Chances are, out of the 8 levels, you're already doing 5. So when you speak to the kitchen, they don't need to be as frightened. So see where your menu can fall already on the IDDSI framework, and we'll show you that next slide, please. Thank you. So we'll see that the NDD, the National Dysphagia Diet, maps over to extremely thick, what's currently spoon or pudding thick. That honey thick becomes moderately thick, and nectar becomes number 2, mildly thick. Also, it's important to point out that food and beverage cross over at levels 3 and 4. The thicknesses and the tests are the same. There's more altered for the food and for the beverage so that they come out in the same place. Please also note that what you're gaining with IDDSI is testing that has been clinically established. Currently, the National Dysphagia Diet is largely subjective, where IDDSI, it is pass, fail, and take corrective action to ensure that you're producing the proper texture modifications for your guests. Next slide, please. Digging a little bit deeper, there are audit tools that are available on the website, as previously mentioned, a wealth of information. It will give you exactly the intended results of your food texture modification and how to test them. So, for example, we have level 4 puree, which includes critical tests of appearance, fork drip test, and or spoon tilt test, and what not to test with, fingers and or chopsticks. For those of you who have not been on the website and looked at all the testing opportunities, this will sound very new, but I can tell you from experience, it is not that foreign once you start to do it. Note on how the food will behave. This is very important for implementation. At the bottom, it says a puree must be able to be put in the mouth and swallowed whole. No chewing and no bolus formation should be needed to eat this consistency. And that testing creates safety for your patients who need this level of diet. Next slide, please. So for menu building, complete IDDSI testing to determine current changes to recipes that you are already performing. Perhaps you already have a pureed meatloaf that you're making. You just only need to add the testing to make sure that it is, in fact, a puree for level. Ensure that your menu contains enough choices for your patients to be able to take care of all of their nutritional and taste needs. You may also want to consider depending on cost, because we have already mentioned that, purchasing pre-made items at the different levels might make sense if you have if staffing is a concern. But if you are a larger facility, certainly it could be potentially more cost effective to produce your own. I strongly recommend, if you don't know where to start on the menu, start with your non-select and work all the way through it at every level. Next slide, please. We've already seen this one, and we will continue to push you towards the website because there is an unbelievable library of work that is available for you to pull down, customize, educate yourself and your teams. Use the resources because you are not alone. Next slide, please. All of the framework documents are available for download on the website. And once you have all those charts and documents, best practice is to designate a dedicated space where all the recipes, all the documentation, any posters, testing tools, food modifying equipment will live. A special place in the kitchen that is dedicated to IDDSI production. Next slide, please. And also, as mentioned before, you will note that all of the tools are available in multiple languages. So you can custom tailor them not only to your staff, but any guest-facing or patient-facing dialogue that needs to take place. Next slide, please. Also, to stay on your path, there are implementation guides that are available that will take you through all of the major areas that need to be touched upon before you go live. And it was already mentioned to lean heavily on your interdisciplinary team. This does take a village. You need everybody involved. Next slide, please. This is more documentation that's available, testing cards, and these would live not only in your recipe books, but in your area where that production and then subsequent service and testing would take place. And next slide, Carrie, back to you.
Thank you, Mike. Now let's talk more about staff training. Who needs to be trained on IDDSI implementation within your facility and the framework? Ideally, this should include anyone whose daily workflow includes IDDSI, such as SLPs, dietitians, kitchen staff, physicians, nurses, and other allied healthcare staff. There might be other staff members not included in this list, dependent upon your facility. Next slide, please. Also consider how you will need to reach all of your identified staff members, and this could be in a variety of ways. Consider providing in-person trainings if able. A town hall format might also prove useful and improve buy-in, which would allow for individuals to ask questions that they might have. Additionally, virtual trainings or FAQs are a nice option to allow for greater flexibility with learning, especially with staff members that are involved or engaged in patient care. Another suggestion is to host optional testing labs for staff, such as registered dietitians and nurses. And by doing something like this, it helps to illustrate the safety behind the IDDSI framework, and it also builds knowledge needed in regard to the importance of testing and the actual framework itself. And, as been mentioned previous times, don't reinvent the wheel. IDDSI.org has numerous resources available, including links to training modules with competencies available for your facility's use. Next slide, please. The staff at your facility might also benefit from reminder emails or updates with the implementation timeline, the process, and where you're currently at. Always include additional resources for those who might want to learn more about the framework and implementation, because you never know who might become an IDDSI champion at your facility. Make sure to hang signage on units and in break rooms to remind staff of the upcoming changes or your go live date. And don't forget to post instructions on how to enter diet orders at MD charting stations. Next slide, please. On this slide, we want to highlight training modules and competencies that we've discussed. If you go to IDDSI.org, you can access these resources and many more. As co-chairs of the US Education and Training Committee, Renee and I often field questions about implementation. The most commonly asked question is always this: my facility is getting ready to implement IDDSI, where do I start? And we always answer this by referring everyone back to the website. We also see many inquiries on social media asking about IDDSI implementation and getting started as well. And again, we encourage everyone to look online. Next slide, please. We've also included a nice infographic that's available on the website. Everything is free for your facility to utilize, but please note that documentation and images cannot be altered and must be utilized as they were created on the website. Next slide, please. Before we get started with our Q&A, Renee and I would like to share our experiences with IDDSI implementation at various healthcare facilities. We thought that this would be a nice way to kind of discuss more about implementation and what it might look like at different facilities. And we thought that it would flow best in this format. So I'd like to go ahead and share my IDDSI implementation journey. When I was working clinically, this was many years before the pandemic. I was part of a hospital that was involved with a healthcare system that consisted of approximately 18 different hospitals across the state that I resided in at the time. And we were told that we were going to implement, and that the larger sister hospitals that were larger in size and had higher acuity levels, that they would be the ones to transition first. And so I started my journey by attending a statewide IDDSI training with that was hosted by speech language pathologists and registered dietitians. And they discussed the process of what it was going to look like for IDDSI implementation at their large hospital, at their facility. And from that, we were given lots of ideas and tips and tricks on how to consider implementation at these smaller sister hospitals. And so I went back to my smaller facility and worked with the director of dietetics to develop a plan to determine how to implement IDDSI at a 200-bed level 3 trauma center. And so all of us were heavily involved in clinical care, and there wasn't a lot of time to be involved in the process. So what we decided would be the best practice is to have an interdisciplinary team that would meet once a week for only 30 minutes during that time period. We always met in the kitchen, and our committee comprised of our director of dietetics. She was our chair of our committee. I was the speech language pathologist representative, and then we had other SLPs that also transitioned that would come in and out to the meetings as well. We had food service workers as well that would be present in the meetings, and then our head chef would be there as well. And what we would do is we started by working through the menu. So we took the menu that we currently had, and every week we tested a different item, and we tested the item. We had somebody on the line create the item to be across the framework. So level 4 puree, level 5 minced and moist, level 6 soft and bite size, level 7 easy to chew, and level 7 regular. And then we would test that item using the IDDSI testing methods, and we would determine whether that item as is on the current menu would pass or fail. And if it didn't pass, then the head chef would work with the food service staff members to determine what needed to be altered or changed to make that work. And so we slowly did that every single week. I believe our projected go live date was 18 months after we got started. And so for us, we worked a little bit at a time, really incrementally, to get everything started. We also worked with the hospital's education department to roll out trainings for nurses and for physicians as well. But what was really nice about that interdisciplinary committee approach is that we would have different members rotate. I would always be there as the speech language pathologist, and the manager of dietetics would always be there, but we would have other registered dietitians and other speech language pathologists rotate in and out. So everybody that was really crucial to knowing more about IDDSI was well trained and really involved and highly motivated and invested in the process. So now I'm going to turn it over to Renee to share more about the implementation journey at her facility.
Thank you. So as mentioned before, I am at a VA hospital. So I am a singular institution, but part of a very big network across the United States. So our journey was a little bit different in that we had to really do our own program, despite the fact that we had a memo from up above saying the VA has accepted this. We are going to use it. Everyone's required to transition. There was some training done for everybody. We had access to webinars from some of the sites that were like the early initiation sites on how they did their process, but we really just had to come up with our own plan. So we also developed a committee. I was the speech pathologist on board. So it was myself, one of the dietitians who was really selected to be the lead of the whole program, a number of other dietitians. We had some other speech pathologists in and out of the meetings, but we started with monthly meetings, coming up with our plan, our timeline, and delegating the work a little bit. We did some initial testing sessions together, but then found, just because of staffing and availability, that we weren't able to really coordinate doing it together every time. So dietitian and our chef took on the testing, food mapping, and menu generation. And then I took on more of the education planning and rollout. So we did a little bit of a divide and conquer, but then would regularly come back together to make sure that we were all working in coordination. We had, our timeline took much longer than it really should have, just because of some staffing. The woman who was in charge, she went on a maternity leave. And so rather than letting us continue, they said everything was on pause. So unfortunately, we had a lot of stop and start and stop and start. And then after we would restart, we would have to back up and redo some work. So I definitely, despite the fact that we had a lot of support from up above, just saying, this is it, we're doing it, it's a directive, we had a lot of challenges along the way, mostly because of staffing. It was a nice collaborative opportunity working in the kitchen and with the chef. One of my favorite things to do along the way was have IDDSI labs. So it's something that I started with the speech pathologist, where we would get together, I would bring foods, we would do kind of exemplars of each level. But then we also had some labs where everybody would bring their lunch, or everybody would bring a snack. So we had really a wide variety of foods and did testing and determined what level are different foods, or if we had this food, how do we think we could maybe cut it or modify it in some way? Would it fit another level for somebody? And then we expanded those labs where we did some diet labs with all the dietitians, but we always had like members of the other teams working together. So I would go to all the dietitian ones. Sometimes we'd have a dietitian come to our speech ones to make sure that it was always a multidisciplinary effort. That is kind of along the way what we were doing. And then with the final transition, we were updating signage. We were, the computer was another challenge, like figuring out how are we going to change diet orders? How are we going to integrate with the system? So we did have a lot of slowdowns along the way. It was a process of years instead of months because we had to stop and start so many times. So I feel like you were in a similar situation to that. Having somebody, or at least a small team of people who's really advocating to continue or kind of picking up those pieces and working together is helpful. So I was one of those people who wanted to keep picking it up. And there was a couple of dietitians and the chef who were really motivated. So despite the fact that we had a lot of setbacks, it is a really positive change, especially for our dysphagic patients. I feel like the food is better. They're safer, more comfortable. We don't have as many food complaints. I'm also at a hospital, if any of you can relate to this, where if something doesn't fit a diet, like when we were on NDD, if something didn't fit a soft diet, they would just give something below it. So someone on a soft diet would get ground up meat, or someone on the ground diet would just get something pureed. People on soft would get puree. So we would get complaints all the time to speech pathologists. Well, oh, they hate their diet so much. They hate this soft diet, but they were getting puree and ground food that they really didn't need. So IDDSI has definitely helped with patient satisfaction on that end. Okay, so I think we can go ahead and switch over to questions now. Luis?
Well, You guys did a wonderful, wonderful, wonderful job. I'd like to remind all our participants today that when you say things like go to the IDDSI website, it sounds really easy, right? Just IDDSI.org. But sometimes people get overwhelmed. So know that our website is now searchable. There are some limitations to that, but that will continue to improve as time goes on. And would you agree that two tabs that are really important are the resources tab and the around the world tab, where we can find direct connection, right, to the US and to other countries and their materials. So that's all great. Also wanted to remind everybody that IDDSI is not a diet. IDDSI is a framework for texture modification with descriptors and testing methods. So I know sometimes people, especially during implementation, oh, we're going to start with the IDDSI diets, but IDDSI is not a diet, right? So those are low carb diets or renal diets, etc. IDDSI is a framework for texture modification and testing. And also the beauty, right? And thank you for talking to us about how to implement this beauty of IDDSI. And the beauty is to have the testing methods, to have the descriptors, and most importantly, to see our patients and persons with dysphagia actually have more than one texture on their plate, which I think is wonderful. So keep that in mind when you're trying to get buy-in. So we do have a few questions for you, and one question is from a colleague who is a part of 26 hospitals and care homes that include both long-term and acute care, and was wondering if you recommend doing the IDDSI implementation process site by site or trying to do all the sites at the same time. We'll grab that one.
I can answer that one. I think it really just depends on your leadership and also kind of the hierarchy of where you work. So, for example, the system that I worked with, everything was really hierarchical. So, what ended up happening is the level 1 trauma centers that were part of the healthcare system where I worked, they always did everything first. They were kind of the guinea pigs. And so that might be something that is already in place. That might be kind of standing hierarchy for that facility where you're at. So that might be something to consider. I think there's positives and there's negatives to transitioning all the sites all at once, right? I think it's also important to note that an acute care hospital is not going to be the same as a long-term care facility. There's going to be a lot of differences among those. And one of the things that we also learned in transitioning our system is that the level 1 trauma center that kind of served as the model for the IDDSI implementation for the system that I worked at, we couldn't apply a lot of those things to our level 3 trauma center. We just didn't have the resources, right? Going from an 800-bed hospital to a 200-bed hospital, there's a difference in resources and access to certain things. And so for us, we realized that we could use that as a model or as a starting point, as a guide, but we had to definitely make some differences. And our menus looked very different as well in terms of menu building. So those are some things to consider. But I think first and foremost, tying it back to what does leadership look like within that system, and how have things been pushed out, or how have things been in the past in terms of other go lives with other procedures or with other changes in the network. I think that's important to look at too.
Great, thank you. Another question has to do with how do we get buy-in when the leader or the food service director, who's also a dietitian, is totally overwhelmed and doesn't even want to think about changing the current system? Any tips or tricks there from any of our panelists? Go ahead, Mike.
I'm happy to take that one. In fully explaining it to the operational food service folks, you have to take the fear out of it. It's not just more work, it's safety. And I'll give you a real life example. I did an implementation, small facility, long-term care, total of 5 cooks, everybody in the room at once, and they were frightened out of their minds. And the first thing I asked them is, do you take temperatures on the line every shift? Yes, chef, we do. Well, why do you do that? Safety. And you have a tool for that. It's called a thermometer and a log. That's all we're doing today, guys. is we're just going to test the food that you haven't been able to and have evidence-based, safe product to serve your residents and guests. And took about 3 hours to have full buy-in kitchen-wide. So
Great.
that is the path of least resistance.
Renee?
Yeah, and if I could add for, I think, dietitians and for speech pathology teams who may not want to get on board, I know we had a little bit of pushback within my department because we have a lot of very skilled therapists who have been working for a very long time. And the idea of we're going to do something completely different than what we've known for all these years is can be a deterrent. But with IDDSI, like we've talked about, it can improve patient satisfaction because foods might have more variety. It's going to be more appropriate for their safety level. And like Mike said, with safety. So safety, patient satisfaction, and truly the tools, once you start to really learn them and explore them, they're very, very user-friendly. So the flow test to see what level liquid it is, the fork pressure test, the spoon tilt test, these are things that we can do bedside. We can do them with our patients. You can do them in the kitchen. Once you're trained on how to do them, they're really very simple. They're easy to teach to patients, teach to family members. So I think just the quality of our ability to train family and patients and our ability to really look at and see if foods are how they're meant to be ultimately saves us time in the future and makes us more effective and more efficient. So it's kind of looking at the light at the end of the tunnel, that it is going to take some time and challenge right now, but ultimately we're all better clinicians for it.
Renee, those were some great points there. The point of service testing, right? Once the tray makes it to the patient, or once the food is prepared and ready for the patient to consume, we need to do some testing at that point, right? That's part of the auditing process. It's not just what leaves the kitchen, but also what makes it to the patient. Hence, you know, the ease with which we could do the testing with a spoon, a fork, chopsticks, etc. So great points there. We do have a question here related to and I'm suspecting the concern here is, so once you've done the mapping, right, you realize that you have to modify some of the foods because you don't have enough for certain levels. How is that tackled by the group that is really focusing on implementing? Any thoughts on how to best manage that?
Well, I can speak to the food piece of it. Part of your mapping is really taking a look, very granular look, sorry, at the ingredient level and making sure that the product that may work for easy to chew 7 can then be further modified to get to a puree. And when speaking with this group, I always use the example of frozen carrots, which are great as a side dish, but you will never get them soft enough to get them to pass a puree for. So, you know, that you look at the ingredient level, look at a pre-cut fresh carrot, which cooks very nicely and goes completely to mush, which is exactly where you want. Did that help answer that question?
I think it did. Any other thoughts or experience from Carrie or Renee? I think that I've implemented at 2 facilities, and the fun part is that when I have to actually you know, sit down with our core team, and the executive chef is usually a part of that, and talk about, okay, so we're short here and we're short there. What do we do? And then the chef and his or her team come up with these great ideas on how to modify, often some level 7s to modify them to level 6 or to level 5. So that collaboration and that buy-in, again, that buy-in from the team is really really important. So let me see. There's another question here, and I'll just read verbatim. My facility is 6 months into implementation. Congratulations, I would say. We have noticed that there are not a lot of resources of instruction or procedures for preparation of minced and moist textures, i.e., how do I prepare a minced and moist quesadilla or grilled cheese? I have an answer, but I'm going to let the panelists tackle that one first. No answers? Oh, Mike, you're jumping in. Thank you.
I will jump in on this one. So that's everybody's favorite sticking point, are the bread items. So there's a couple ways around that. You could use a pureed bread mix, if to get some bind in that level 5, and you take the filling to a level 5 and you bind it with the pureed bread. That works well. Um, the other piece could be working around that particular menu item, and not putting it on that level, or just serving, the just the filling that you can manage. But if you don't have a pureed bread mix, or you don't have a product, it's very difficult to get that level. And oatmeal is another great example, to get fine enough if you have to take that to a puree. I've actually had great success pulverizing the oatmeal first and then cooking it. But that's why you need the culinary staff to be all in, because they will get creative. They will find a way.
Right. And while, IDDSI again talks about the framework is for texture modification and for the testing methods, we do not generate recipes. However, people do share recipes, and there's actually a reference group being formed now by so many of the chefs that we have in our different reference groups around the world, who will be coming together. And so in our eBite newsletter, which if you don't receive monthly, you should subscribe to on our website, there will be more information as to some of the recommendations that chefs and folks in the culinary world will be sharing. There also are some diet books, etc., out there that have incorporated IDDSI and might help facilitate that that process. Let me see. So there's a question here about, can we implement IDDSI? Do we have to implement it in its entirety, or can we just implement the foods, or just implement the liquids? How should we handle that? What are your thoughts, panelists?
I can take this one. It is your facility's decision what levels you implement, just like this whole time it's been your decision on what diets to use. The key is that the levels that you do use follow the framework's guidelines, that you don't change the names, the labels, anything associated with it. But for example, we don't use slightly thick as one of our liquid levels. It's not something used so much outside of the pediatric population. So we just do not have that. We don't include it on our recommendations. We don't have it in the diet orders. It is as if it does not exist to our hospital system, but we have not changed or modified those levels that we are choosing to follow.
Okay, there are a few other questions that are really more food specific, not focused on implementation, which is what we are heading for here. Several questions on bread. So I just would like to direct folks to actually in the across the world tab in the IDDSI website. If you go to United States, the US IDDSI reference group has a handout talking about bread and putting together the information that we have available on the IDDSI website. Of course, you can also search for that in the main IDDSI website and find some of the FAQs on bread. So that will help that. Let's see. Someone's complaining that their residents from their facility go to the hospital and come back on texture modified diets that are not following the IDDSI framework. I mean, the reality is we're all implementing, right? So hopefully one day, not too far away, we'll all be speaking the same language. I would say, let's see. Here's another one. Again, it's more specific to some of the food modifications. However, this question is anyone familiar with Meal Suite? My long-term care skilled nursing facility plans to adopt this program for their menus, and I have been told that this program apparently has already tested all of its items on their menus and other options for IDDSI levels. I'm an SLP and have not yet been able to see what these menus look like. Any experience or suggestions? I'll tell you while you panelists. Oh, Renee, you were going to jump in. Go ahead.
No, it was just silent. So I was going to say, I'm sorry, I'm not familiar with that
Oh,
program.
I'm not familiar with it either, but I was going to say because I'll tell you, the facilities where I've implemented were in Brooklyn, New York, right? And so a large population that follows kosher meals, and some hospitals will import the kosher meals from the outside. And so the company that was being used said, "Oh yes, we'll go ahead and follow IDDSI," and they delivered some items in that process of implementing IDDSI in their kitchens to prepare the kosher meals for us. And we then did the testing. I mean, the bottom line is, if there are recipes or menus that are going to be used at your facility, the bottom line and the last word always is testing, right? So test those items, test them in the kitchen, test them at bedside, and make sure that they're compliant with the different IDDSI levels. Mike, were you going to say something?
Yes, I am familiar with that program and where the recipes might be built with certain directions on how to alter the texture. It does not remove the need to test locally. So grab your chef and all his friends and start running through the recipe. And then to your point, not only do you test it at point of fabrication, but also at point of delivery, because as food cools in transit, it can a perfect pass could fail by the time it gets to its intended guest. So it's important that everything get tested, and just because a batch passed and then sits on a steam table or in hot holding or in cold holding, depending on what you're making, for several hours, you could have a change in texture that would cause it to fail. So you have to practice.
Yeah, and if I could add to
Very good
that,
point.
we had a lot of trouble with the minced and moist level, as many do. So our facility was choosing to get some prepared products from a vendor, and they would send us samples to try. And some of them we tested and didn't find that the pieces truly were the right size, or some of them were really too tough; they weren't mashable. So we did our own testing there, and we gave feedback to the vendor. And they ended up sending somebody out, and we did testing together and had a conversation about the different products. And then they took that feedback back to their labs, their kitchens, the people who are preparing these to go out with the label of IDDSI minced and moist on it. So I would definitely encourage you, if you're trying things from vendors, to give that information back to their representatives. Try to talk about IDDSI. Here's the testing. Here's what we did. Here's what we're seeing, because they may be very receptive to that information and make changes to the benefit of many.
Great. We have two more questions here about that are specific to some of the implementation thoughts and ideas you might share. One is specifically, how do you recommend dividing and conquering when it comes to deciding how to rate the foods, or again, that menu mapping? You've already provided a few ideas. Any other thoughts on how to divide and conquer and how to make that work? And over how long?
I think it really comes back to your facility and your staffing. There's no great formula for that. I think you need to look at who could have protected time for it. We tended to use the dietetic interns a lot, give them training, and then have them do it as part of their extended placements at our facility. It's definitely a manpower issue that could be a barrier to timely completion, but it just comes back to what your staffing looks like, unfortunately.
That's a good point, right? We know of some places around the globe where there's been one speech pathologist and one dietitian mostly doing that in collaboration with the kitchen, right? Because the kitchen prepares the items. I'll tell you that at our large facility was at that point we were implementing, it was 640 beds. We created 6 teams of one speech pathologist, one dietitian, and then we coordinated with the kitchen over 8 weeks. And we took different turns between breakfast, lunch, and dinner to do the testing. And then we retested about 20% of those to make sure. And we used the audit sheets that are available on the IDDSI website to make sure that we kept track also of our notes and suggestions to discuss later with the kitchen team on some modifications that might be needed to make it compliant. So in every place, it's kind of different, right, in terms of how that's orchestrated. The other question, let's see if I find it again. Oh, suggestions on training and how to get everyone on the same page regarding. This is more specific regarding things like sticky texture. Some people say it's fine, others say it fails. So what are your thoughts on that?
I can share it more generally, not necessarily specifically related to the sticky issue. But the facility where I worked when I implemented IDDSI, we had a huge issue with staff turnover in the kitchen. And that had to do with the fact that a lot of our kitchen staff were actually university students. So they would, come and go quite frequently. So one of the things that we discussed, like in our IDDSI team, because we identified that as a barrier really early on to the implementation process, we talked about how for new hires that they should do some type of IDDSI training even before we went live. And so all of the new staff that were onboarded in the kitchen, and also dietitians and speech language pathologists, they were completing some online like IDDSI modules, like from the website. The healthcare system I worked for also had kind of like a basic guideline of here it is and here's testing and those types of things. So I would recommend that, like getting them trained with IDDSI like the moment they start onboarding. That should really be part of the onboarding process for anybody that's going to be involved in IDDSI.
All good points. We have just a few more minutes. I'm going to read this one verbatim to make sure we all get we get the idea of the question. Are most facilities providing all of their therapeutic diets, i.e. low sodium, consistent carb, modified to every IDDSI texture? Or is the assumption that intake should allow to be optimized on these altered texture diets?
I can answer that one too. We did that. So all of our IDDSI diets can be built into any type of therapeutic, whether it's like renal, low sodium, like whatever that might be. But one of the things that a lot of facilities do, is my understanding, is that's a great role for the dietitian to work with the physician to determine if the therapeutic diet is needed on top of the IDDSI framework. So that's something that I think is can be really beneficial for the patient to work with dietitian and MD hospitalist to determine if the therapeutic diet is really needed.
Wonderful. Any pearls of wisdom that you would like to share as we are wrapping this session up?
I would share, from start to finish, it feels overwhelming and it feels really daunting. It's a marathon, not a sprint, but like Renee alluded to, in the end, it's worth it, because at the end of the day, the patients matter and the families matter. And if you're in a school-based setting, your students matter. And so you have to really think of it in terms of you're doing this to benefit the patients and families that you serve, and they truly deserve your best work.
Wonderful. Thanks, Carrie. Renee?
I would just say stick with it, because it is good in the end. A lot of times on these panels and these talks, I feel like a lot of my colleagues in this IDDSI sphere have these really great stories of implementation. And I am here to tell you that even though I have been a part of this for a long time, I love it, it was not like that for me. It was not like that in my facility. And we had a lot of stops and starts and a lot of challenges along the way, but we stuck with it for the benefit of our patients and for the benefit of our kind of global communication. So don't give up.
Great points. Mike?
You can do it. You can do it.
Wonderful.
All change is scary at first, messy in the middle, and gorgeous at the end.
That's true.
Have
That's
faith in
true.
yourself and your team and go for it. Your
Wonderful. Well,
patients will
I'd like
thank
to,
you.
on behalf of IDDSI Global, I'd like to thank our 3 panelists today. You did a wonderful job at really introducing us to implementation. And of course, there are many more questions and many more concerns about the process. Please do consider joining us at the US IDDSI Symposium on July 25th in Newport Beach, California. CEUs will be offered for SLPs, for dietitians, and for certified dietary managers. So those are in process, but hopefully soon we will confirm that those will be offered. I also want to mention that, yes, definitely go to the IDDSI website for your answers. If you can't find them, you can either send general questions to IDDSI Global, or again, go to Across the World, go to US, and you can send an email directly to the US IDDSI reference group. And they might be able to also guide you to look through some of the materials available on the IDDSI website, but also available in the US IRG website. So thank you once again, panelists, you were wonderful. Thank you to all the participants for being here, and do stay in touch, and I hope to see you July 25th. Thanks very much.
Thank you. Thanks, everyone.